I'm now joined by geneticist, consultant, and associate professor of biotechnology at the University of Trinidad and Tobago, Dr. Nicole Ramlachan. She's with us via Zoom. Good morning, doctor.
Good morning.
Well, thank you very much for joining me. COVID-19, as a global health emergency, the WHO has declared it's no longer a global health emergency. But exactly what does this mean? Because we've seen some confusion, even within the press, who have suggested that the pandemic is over. Some are suggesting it's not. It just means that emergency measures are no longer necessary. Could you kindly explain to us, from a medical standpoint, what this means?
Sure. Okay. Good morning, viewers. Thanks for having me. Well, I mean, of course, they're going to pick up on the words that everybody wants to hear, which means it's over, right? Something is over, yes, but what's over is the acute phase of pandemic response, really. So from a management standpoint, from the WHO standpoint in particular, they have ended their emergency public health authorization, which gives them control of certain things and instructs countries themselves and how to have different protocols to put into place, and all of those things that started all of those isolation protocols and the quarantine protocols and all of that was actually due to the declaration of the WHO declaring the COVID-19 infections around the world, number one, as a pandemic, and two, as a public health emergency. So it was more of a management tool, really, and more or less like an alert tool. So like those of you who've driven in the US and stuff, and you see these amber alerts, and sometimes it comes on your phone, and you see these things on television. You'll see them flashing across the big screens on all over the place when there's a child that's been kidnapped or something like that. It's an alert. And that's basically, in essence, what the WHO did with this public health emergency, to alert the world that, yes, we do have a situation and we have to put these things into place in order for this to be controlled. So it's more of a management, end of the management part of it is really what it is. What they've now implemented is something called a strategic response for the next 2 years, 2023 to 2025, that goes along with their 10 pillars, where they're trying to reduce the effect of long COVID, of management strategies, of allowing the healthcare system that's present in most countries that did not have available healthcare, that system that's now been set up to deal with the emergency that was COVID, can now be implemented as a permanent strategy to be able to deal with possible other COVID-like or epidemic-like infections in those countries that are lower served, really, or less served by by these strategies that we have here in Trinidad, and even in the first world countries that are more more well funded and more organized.
Well, speak to me now about the strength of the actual virus. We have seen downward trends. We've seen globally. We've seen more people getting vaccinated, although hesitancy still exists. Does this allow, though, for people to return to a sense of normalcy pre-pandemic levels?
Well, I mean, I think at this point you can't really say pre-pandemic levels will ever be. I don't think any of us will ever be the same. Mm-hmm. I think there's going to be strategies that will be permanent, and there's going to be things that are still. I mean, here in Trinidad, we still have to wear masks when we go into healthcare facilities and doctors' offices, and even if you go by the dentist and those kinds of things. And those are strategies that might be here for a little while, just because you're less likely to catch something in an environment where people are most likely to be ill. And that's the strategy with that. It's not that anybody's trying to say that we're at the same levels. It just means it's giving those people who are elderly, people who are sick, who are the ones who are usually going to the doctor, going to the healthcare facilities, going to the hospitals more often. You're giving them a little chance to perhaps not catch something that day. Because if you have a little runny nose and you have a little illness and you have on a mask and you are able to protect yourself from spreading that and protect others, then that is that's a good thing. So the virus itself is here to stay. And that's really what the answer is. Just like influenza, which has been the cause of several pandemics, including the Spanish flu in 1918, that killed over estimates of 50 million people. We know that the next epidemic is just over the horizon. That is how these things evolve. Now, viruses like respiratory viruses like influenza and COVID-19, which is a coronavirus, and of which we had a pandemic that a lot of people don't remember. In 2002, 2003, there was a worldwide pandemic of the previous SARS that was related to this SARS, and that it's a coronavirus, but it wasn't, of course, as contagious. So we were able to actually contain that very quickly in a few months, and the people who got it were the people who handled the individuals who traveled, but it was far less contagious and much more able for us to be able to contain to a very small number of people, although it was worldwide and it was spread worldwide. So these things happen all the time. So viruses are going to evolve to want to be able to coexist with their host, because viruses are non-living things. They cannot live outside of a host. So at the end of the day, killing the host is not going to be very good virus strategy in virus evolution, because they would have nowhere to live and nowhere to live, but nowhere to reproduce and nowhere to exist. So eventually we're going to get to a point where how influenza is, in that it's going to change all the time, because the respiratory viruses are very antigenic. What does that mean? That means that the proteins that stick out on the surface of the cells keep changing because they want to adapt to different types of cells, different types of hosts. So that Omicron that we have now, and the Omicron in particular, the 1.16.1, which is the latest version that's now going to probably replace all the other ones that we've had earlier, is very well adapted at getting into the ACE2 receptor. And that ACE2 receptor, unfortunately, is present in many other cells other than those in your respiratory tract. They're present in your pancreas, they're present in your heart, they're present in your liver, tissue, many, many other cell types. So what you're finding now is that the Omicron infections, and the reason why those are increasing is because they're now much better at getting into cells. So they're much more contagious. That's what that means. It's not getting that deep, long infection we used to see with the Delta and the earlier varieties, because they don't need those receptors anymore. They now have adapted to become much more versatile. So you'll notice now everybody getting like conjunctivitis, upper respiratory infection. It's kind of staying around here because those are the cells that have these ACE2 receptors. However, what we're also seeing is the long COVID effects. People are sick much longer. People are getting heart attacks. People are getting stroke. People are getting diabetes. Young children who've never had type 1 diabetes all of a sudden have type 1 diabetes post-COVID infection, because the virus is going all over the place and getting infecting cells that we didn't previously realize were targets because they weren't, and now staying there and causing a lot of problems for people. So we're going to be with this virus for a very long time. What is the strategy of the World Health Organization and management strategies of government is to say, okay, well, listen, we have to get back to some level of normalcy. So all of these things that we've had to try to protect the population, for example, in the US, the May 11th, on May 11th, which is tomorrow, there's no more restrictions on flights from international countries and so on coming in vaccinated. Those things are all lifted. So basically, we're getting to the management level that is pre-pandemic. That's basically what they're saying, that we're just trying to manage the situation as a normal virus. So we're treating COVID-19, SARS-CoV-2, like we would an influenza outbreak, or something that we've lived with. Because by now, more than 80% of the world, roughly, less than certain countries and more in other countries, but our overall average have some level of immunity, or have had some level of infection or reinfection, or some level of immunization that is covering them. And what we used to call the herd immunity that we were after for a very long period of time is now about, roughly about 80%, which is what you would expect after a period of 2 to 3 to or going on 4 years now.
Dr. Ramlachan, I think you've explained this brilliantly, but And though you've also acknowledged, and we acknowledge, that the virus is here to stay and viruses tend to evolve, though those levels of herd immunity, that goal, we seem to have realized that goal, what is the possibility of a new, stronger variant emerging, and even us having to once more be in a global health emergency? Have we considered that?
Well, of course. I mean, there's always the next pandemic, the next virus. Over the horizon. Everyone who has been following this and everyone who's been living it is very well aware. Pretty much the cycle is every 3 to 4 weeks, a new variant kind of almost takes over and becomes dominant. Does that mean that that's only what there was? No, there's been hundreds of variants of just the SARS-CoV-2 since its emergence in 2019. And that has that's basically evolution of viruses. So the same thing happens with influenza. With influenza, we've had to adapt our immunization protocol because it changes so much. So now every year you have to get, or it's recommended that you get an influenza vaccine that consists of 4 variants, right? Because it is so mutatable. And we know that exists with influenza. We have other types of viruses which we give multivalent vaccines. And that's what's happened now with the SARS-CoV-2 vaccine. It's now a bivalent. So there is the Omicron version in it, antigens, and it's the previous antigens to one of the original forms, or the original form that came out of Wuhan in 2019. Since then, we know now it's now mutating again, and it's mutating again, it's mutating again. So what we're probably going to have to do is use the influenza vaccine model, where every year they're going to have to try to see, okay, well, what's the prediction for what might be in circulation next year, which is what they would do with flu, and they develop a vaccine and they make that available the following year. So you have to kind of think in advance, look at the strategies of individuals who do the genomic sequencing and so on around the world, look at what's in circulation and try to predict for the next flu season, as we call it, the next respiratory viral season, which is going to, what's going to happen is COVID-19 is going to peak just like those normal respiratory viruses like flu and cold viruses and all these things that we have. We're going to have a season. But we're also going to have the appearance of the odd variant every now and then that breaks through, becomes more contagious, becomes more able to evade the immune system. So what we're seeing is less effective vaccines, especially the original vaccines, because those variants are no longer in circulation. Right? The vaccines that we developed 2.5 years ago were against variants that do not exist anymore. Yes. So they're going to have a certain amount of efficacy against these new variants, but it's going to be like in the 30%, 35%. So if you go get boosted, here locally in Trinidad, we have the Sinopharm, I believe still, and others that the immunocompromised people and the elderly can get boosted. I think they're saying every 6 months or so. And that's fine. It's going to give you a certain amount of protection. But it's the same thing with the flu vaccine. The flu vaccine is no more effective than 30%, and it never has been for several years, because we aren't able to necessarily predict what's in circulation so far in advance. And it's like a kind of hit or miss thing. Sometimes we get it and sometimes we don't, right? And there's certain variants that we're going to put in there all the time. For example, swine flu. Swine flu is always in the influenza and for the last few years, always in that model of that multivalent, because we know it's going to be circulating. So that's going to probably happen. We're probably going to know that Omicron or some variant of Omicron is going to be around, but there's going to probably be some other things that we're going to have to put in there, and we're going to start having to develop. And it's happening. People are spending their money behind it and getting to the point where they're going to produce bivalent, multivalent vaccines that are going to be available for purchase. What's happening too at the end of the emergency health authorization is a lot of the freeness what the government's paying for a lot of things is going to be over. And individuals are going to have to put that into their normal immunization protocol as they would for their children going into schools and those kinds of things. It's not part of the mandate right now in Trinidad. I don't work for the Ministry of Health, so I don't know if they intend to do that. It is recommended, of course, around the world for all children over the age of 6 months. And that's going to be how it's going to be. It's going to be that part of the protocol, and it's going to be something that's going to be more or less voluntary, unless, of course, they put it into the mandates to get into schools. And then if you want your child to be in a public school or public university, if you want to attend a public university and so on, you might be required to be vaccinated, just as we are now, against over 14 or 15 different vaccine treatable diseases.
I think that is something that people wouldn't want to hear. I still need to go get my COVID-19 vaccine.
It's a reality. Yeah. You vaccinate your child to go to school, so what's the problem?
Well, the vaccine hesitancy still exists, and now that the global health emergency is over, I've already heard some skeptics say, well, good, you see, I was right all the time. There was no need for me to get the COVID-19 vaccine, and I'm not going to get it still. So
people are still dying every day, and that's the reality of the situation.
And that is...
People are still immunocompromised. People are still affected. Up until 2 weeks ago, one of my family friends passed away from COVID-19, nothing else.
So that is another concern I have, Dr. Ramlachan, because as much as we've seen globally, we've seen downward trends in the number of new emerging cases. Dr. Tedros of the WHO, he acknowledged that there's still many people dying, there's still many people fighting for their life, and ICUs around the world are still full to capacity. So now that we're moving into long-term management, we're aware of what governments need to do in terms of long-term management. But given that people are still fighting for their lives and even fighting the long-term effects of the COVID-19 infection. What is required from us as people now to try and ensure that, listen, we do our part in managing this virus long-term?
Well, I mean, a lot of it is social responsibility, right? I mean, we always say that over and over again. In healthcare, you are your brother's keeper. And unfortunately, even with the healthcare workers, we saw a lot of people who were not vaccinated, who are in the depths of things, who are treating patients and refuse to be vaccinated because it's not mandated. And that's something that, that is, as far as I'm concerned, unacceptable. Very irresponsible. And that's something that we have to move towards eliminating. And it's really through education and through things like this where I try to myself, and I've dedicated a lot of time and energy to do that, to try to debunk the myths and the misinformation. We had a whole YouTube series. We have over 15 sessions over hour long. If anybody wants to see it, they can see it. Through Gen X, we've done a lot of education, educational and media, little blurbs, little things like this, some TikToks, all of these different things, strategies to be able to get into the mass population, perspective, so to say, listen, this is the facts and this is the truth. This week, what we celebrated this week? The 42nd anniversary of the eradication of smallpox. How did we eradicate smallpox? We vaccinated. And there was no other way. The strategy was to, of course, spread that word around the world. We did it. We were able to eradicate it. And it's really through vaccination strategies, through avoidance of spreading disease. And that's just basic common sense. If you are ill, do not go around people who you do not want to infect. Mm-hmm. If you have an 89-year-old grandmother, mother, aunt, uncle, you have people who have cancer, you have young children, don't go around them. If your child is sick, keep them home. Do not send them to school. If your child is sick, do not drop them by your 89-year-old mother to take care of, knowing that they're sick and knowing they might be able to spread the disease to them and other people around them who do not have the immunity to be able to fight it or immunocompromised for other different reasons. That it is a strategy of really, as I said, be a brother's keeper and be socially responsible. If you know that you go into the grocery and your nose is running and you're sneezing and stuff, put on a mask and go into people's grocery. Don't go and sneeze up on the vegetables and then wipe your hands as you're picking up fruits. And I mean, it just makes sense. A lot of these businesses no longer have the washing facilities outside, and that's fine. You walk with your bottle of sanitizer, you wear your mask. If you are going to a very crowded place, if you're going into churches, even sometimes some churches, I know some people, elderly people in particular, who are susceptible will wear their masks when they would sit into the church, especially if it's air conditioned and they don't have the circulating of air. Those kinds of things. It's just really basic common sense. If you're in an office and it's closed up all the time, air circulating all the time, try to eat your lunch outside. Mm-hmm. Try to, open a window if you can every now and then and circulate some air. Try to put on a fan. If you are in a classroom and your classroom doesn't have any AC, make sure that you have fan circulating. If it does have AC, open a window and put on a fan every now and then. Every hour or two, take a break. Have the kids walk outside, I mean, they're doing that already in the the educational system have been first-line responses, and I always say that the teachers, kudos to them. Everybody always talks about the healthcare workers, but I always have to give kudos to the teachers who came out very early around the world in this pandemic. A lot earlier in some other countries. Trinidad wasn't as early. We were one of the latest to open, but still, and really first line workers mm-hmm. At the first line of these things and having to deal with it. And their strategies have been good because really, even though we have a lot of cases in Trinidad, still relatively per capita, we still have a lot of deaths. I think we have done a good job as a population. I still see people wearing their masks in public. I still see people bumping elbows and not hugging up and shaking up hands when they see, when they try to greet elderly people and so on. And I say kudos to you.
Dr. Ramlachan, we have my apologies for having to interject because we only have about 2 minutes left. But my final question to you is, again, thank you for the information that you shared. Long-term management, of course, the virus is here to stay, and you still need to get vaccinated, of course. A personal responsibility and social responsibility. But do we have an understanding as yet as per the long-term effects of COVID-19, or is that still something that scientists and doctors around the world are still studying?
Well, obviously, we know what's happened for the last 4 years, right? We don't know what's happened for 10 years because 10 years hasn't passed. So obviously, we're going to have to keep on getting more and more information. The long-term effects are, it's obvious, the virus affects many different cell types around the body, many different organs in ways that we didn't know that could be affected because it was a novel virus. So what does that mean? That means that the human population had never seen it before. So we're not sure exactly how that virus is going to be able to leave the body and leave the body unscathed. We didn't know that was going to happen, and we know now it did not happen. So there are many people who are suffering long-term COVID effects up to 4 years, which is now, after their initial infections. Some individuals have not been able to even regain walking, driving, still have to have breathing or apparatus. In some cases, have mental health problems. By the way, this month is mental health awareness. So we have to say, a shout out to those individuals who are working very hard to be able to adapt, have people adapt to this new world that we're living in post-COVID. Because COVID really took a toll on people's mental health, but it also, the infection itself, we know, did a lot of damage in the brain as well. So there's a lot of information that's coming out day to day. The main thing to take home is that there's quite a bit of long-term effects that we don't know. So you need, if you've had a COVID-19 infection, even if you haven't had a COVID-19 infection, it's very important for you to go and do your normal checks, especially if you're over 35, do your mammograms, do your prostate tests if you're a female, if you're a male, do your heart checkups. Do your heart and lung basically go as one, but you should try to do checkups a little more often than you would as people who don't go, once every 10 years. Try to go now and take a overall look at what's happening to your health so that you can know how to respond. We really don't know. We know that it is very negative for individuals who are immunocompromised, people who have obesity, people who have cardiac issues, people who have diabetes, people who have cancer, pregnancies. Very, very dangerous in those individuals, and long-term effects have been documented and are being documented. But more and more research is coming up to show that we really don't know the extent, number one. And two, there's a lot of surprising damage and a lot of long-term effects from individuals who've even had very mild infections. So don't feel because you didn't have COVID or you didn't think you had COVID, you never tested positive, or you had very mild symptoms, that you've gotten away unscathed.
Dr. Ramlachan, I want to thank you very much for joining me this morning, and you've certainly shed some light and given us some more insights, because as I mentioned earlier, the whole point of this conversation is people think this is over. People think we're out of it and we're done with it. So I'm glad that you've actually focused on what has happened, what is happening, and the possibilities that can arise. Thank you very much for your time this morning and for your explanation. Keep well, Dr. Ramlachan.
You as well. Take care, everybody.
Bye-bye.